In this lecture, we discuss on gastrointestinal tract and the abdominal wall. Let's say anterior abdomen. So before we start that, let's remind ourselves and let's think ourselves as a clinician. And if you are looking at someone's abdomen, what I want you to remember is, I want you to remember this diagram, which is the 4 quadrants of the anterior abdomen. So in midline, which is crossing the umbilicus vertically, and another line, which is running horizontally across the umbilicus. We divide the anterior abdomen into 4 quadrants: right upper quadrant, right lower quadrant, and left upper quadrant and left lower quadrant. This knowledge is important because you are going to relate the underlying intra-abdominal structures depending on which quadrants you are putting your palpating hands, examining hands. Right, so in the right upper quadrant, let's say we have the liver and the gallbladder. Right lower quadrant, we will say cecum and the appendix. Left upper quadrant, stomach, might be some part of the intestine, and might be spleen if it is enlarged enough. And in the left lower quadrant, we will have descending colon, sigmoid colon. So this is an important information. So if you have that information, then I want you to take a next step. Like, we are dividing the anterior abdominal wall into 9 regions. So we have 2 vertical lines, which are running from the midpoint of the clavicle, one on the right side and one on the left side, as you can see here, and another 2 horizontal lines, which are running just below the costal margin, which is called subcostal plane, and another horizontal line, which are touching the right and left iliac crest tubercle, intertubercular line. And by running these 4 imaginary lines, we are dividing the anterior abdominal wall into 9 regions. So this gives us a little bit more specific location with regards to the examining hand across the anterior abdominal wall. Why are these important? Of course, one day you might be somebody who is going to do surgical incisions on patient, and depending on which incision and which organ you are going to use, you are going to put your surgical incision in the appropriate site. So these are just examples. For example, like the coccus incision, which is in the subcostal plane, which will get access to the liver and gallbladder. Let's say gridiron or lens incision, they will get access to the appendix, which is in the right lower quadrant, and so on. Of course, these are the oblique incisions we are going to put on the patient's abdomen. And there are also vertical incisions, which I want you to appreciate. Of course, once you take the scalpel, like knife, and put it on the patient's skin, so these are the structures you are going to cut through to get into the intra-abdominal organs. The first thing is skin. Of course, skin is made of epidermis and dermis. And there is a subdermis layer, which is called hypodermis, which is mainly some amount of fat. And then we get to the deep fascia. And finally, in the limb, we get down to the muscle. But if we are putting the skin incision on the anterior abdominal wall, we will have to go through different layers. Of course, number one is the skin, which is made of epidermis and dermis. Depending on what type of incision you are using and which part of the abdomen you are making the incision on, you will be going through these muscle plates. So the knowledge of anterior abdominal wall muscle become important. So what are the anterior abdominal wall muscles? They are external oblique, internal oblique, and transversus abdominis. Look at that. External oblique, which is running downwards and medially. The direction of the external oblique is the same as external intercostal muscles in the thorax. They are running downwards and medially. As we remember, internal oblique, they will run opposite to the external oblique muscle. And transversus abdominis muscle, they will be running horizontally. If we look at more carefully, this external oblique upon external oblique muscle, once it gets around the mid-clavicular line, it becomes white out structure. Here we can see the muscular layer, and now in the more of the center, we can see the white out fascia layer, which we call aponeurosis. So which means this aponeurosis is coming from the external oblique muscle. And now we are looking at the external oblique and other abdominal muscles again. We have the downwards and medially oriented external oblique, downwards and laterally directed internal oblique, and horizontally running transversus abdominis muscle. And in the center, we have left rectus and right rectus sheath. And if you look at the origin of these muscles, they are all originating from the thoracic cage and ribs and the ilium. And in the midline, as we remember, like we have the left rectus muscle and right rectus muscle. This diagram is just pointing in the midline where there is no muscle. It is just the aponeurosis, which is white color, and therefore we will call it linear, which means lines, alba, white, linear, alba, white line, which is in the center. So these are the muscles of the anterior abdominal wall. And let us quickly go through the posterior wall in the abdominal region, which we call lumbar. So at this stage, we only try to remember the superficial muscles of the posterior wall. And what I want you to remember is this big, large muscle, which is called latissimus dorsi. Latissimus means large, dorsi means back, posterior. So large muscle in the back, latissimus dorsi. And here in the upper quadrant, trapezoidal muscle, which we call trapezius muscle. Right, we will just leave it there. And of course, this, latissimus dorsi in the center around the lumbar spine, that is called lumbar fascia. Now let's go back to the anterior abdominal wall. So these are the three muscles of the anterior abdominal wall: external oblique, internal oblique, and transversus abdominis. These are the muscles, and these are the fascias, which is colored with green, covering the muscles here. And if you remember, the fascia, which is covering the internal oblique, will split into anterior leaf and posterior leaf. The anterior leaflet will go and merge with the fascia from the external oblique. They will fuse together. The posterior leaflet will go and fuse with the transversus abdominis aponeurosis, they were all fused. And now we have created a pouch or pocket in which our rectus masseter sits. And this is what we call the rectus sheath. Of course, anterior rectus sheath and posterior rectus sheath, which envelopes the rectus masseter, they will meet in the center to become the linea alba. So these are the three masseters. On top of these three masseters, external oblique, internal oblique, and transversus abdominis, their fascias fuse and form the anterior rectus sheath and posterior rectus sheath and meet in the center as linea alba. There is one more fascia layer, which we call transversalis fascia, posterior to it, and the innermost is the peritoneum. After the peritoneum, we will get to the abdominal viscera, intra-abdominal contents. So now let's have a look. External oblique masseter, which become the anterior rectus sheath, which is enveloping the rectus abdominis masseter. And here, this is the, if we remove the rectus masseter, this is the posterior rectus sheath. Posterior rectus sheath just ends somewhere midway between the umbilicus and the pubic symphysis. This area where the posterior rectus sheath ends, that is called arcuate line. So what's happened below the level of the arcuate line? All the muscles and the fascia, they do not form rectus sheath anymore. They will all march and runs in front of the rectus sheath. And therefore, there is no posterior rectus sheath. And therefore, we are left with the transversus abdominis fascia, transversalis fascia, somewhere around here. So that creates the arcuate line. And now we go back to our very first lecture, and which is showing the body cavities. As you remember, we have dorsal body cavity and ventral body cavity. Dorsal body cavity include cranial cavity and spinal vertebral cavity. In the spinal and cranial cavity, we have brain and our spinal cord. In the ventral body cavities include thoracic cavity, abdominal cavity, and pelvic cavity. So we are going to concentrate on abdominal cavity. So let's say now we have get through the anterior abdominal wall, and we have gone through the different layers of muscles. And once we open it and open the transversalis fascia and we open the peritoneum, this is what we are going to see. What is this yellow sheet? This is the greater omentum, which is covering all the viscera, intestine. And if you want to see the intestine, you have to lift up this omentum, greater omentum. So roughly, what are the abdominal contents? Of course, very small portion of the esophagus, like about 2 centimeters in the abdomen. And after that, we have the stomach. Stomach has got larger curvature, which we call greater curvature, and smaller curvature, which we call lesser curvature. And then we have duodenum. Duodenum will be followed by jejunum. Jejunum will continue as ileum, Ileum will go and join to the cecum. This is the ileocecal junction. Cecum will goes upward as a ascending colon, and it will cross to the left side as transverse colon, and it will come down as descending colon, and finally it becomes sigmoid shape, which is called sigmoid colon, and finally it will end up with rectum and anal canal. So this is the very rough idea of the gastrointestinal tract. But let's say if we want to do gastrographin follow through, like the patient has to swallow the gastrographin, and the gastrographin will enter into the stomach. And from the stomach, it will continue into a C-shaped loop. That is the duodenum. And then from the duodenum, it will continue into the jejunum. If you look at the jejunum, it is like a accordion, which has concertina, and therefore we call that concertina effect. We will see concertina effect in the jejunum. And that jejunum will continue as the characterless ileum. So it's just a tubular structure, which is running, which is part of the small intestine ileum. And that ileum, it will go into the ileocecal junction and then finally into the cecum. And from the cecum, it will become, which is the first part of the large intestine, and which will continue as ascending colon, which is going up, which is going to the left side, which is called transverse colon, and finally come down, which we call descending colon, and finally becomes sigmoid shape, which we call sigmoid colon, and finally it will go into the rectum and anal canal. And the characteristics of the large intestine is these bulge here, multiple bulge here. These are what we call hostrations, like this big hostrations here, and keep going there. These are the characteristics of the large intestine. So now again, we are looking at the large colon, which is made of starting at the cecum, ascending colon, transverse colon, descending colon, and then sigmoid colon, rectum, and the anal canal. So now we need to recall our memory from the blood vessels. If you remember, this is our abdominal aorta, which we divide into right and left common iliac arteries. And the abdominal aorta has 3 unpaired branches. Unpaired branches, the top one is celiac artery, which is somewhere around here. Well, it's written here, celiac artery here. The second unpaired branch is superior mesenteric artery here, and the lowest is inferior mesenteric artery here. So these are the unpaired branches from the abdominal aorta. And as a reminder, the paired branches, which means like we have right and left arteries, they are renal artery and gonadal arteries. Yes, if you look at that, celiac trunk artery, it will go to the liver. Celiac trunk artery will go to the spleen, and celiac trunk artery will go to the stomach. Superior mesenteric artery, if you look at that, it will go to the small intestine. Yeah, you can see the superior mesenteric artery is giving blood supply to the small intestine and to large portion of the large intestine. To be more specific, up to the right 2/3 of the transverse colon. And inferior mesenteric artery, we give blood supply to left 1/3 of the transverse colon and descending colon and sigmoid colon. So these are the blood supply of the gastrointestinal tract. So stomach, liver, gallbladder is supplied by the celiac trunk, superior mesenteric artery for the small intestine, and large intestine, which is down to the anterior 2/3 of the transverse colon, and inferior mesenteric artery, we give blood supply to left 1/3 of the transverse colon plus descending colon and sigmoid colon. Now I want you to take a break. I want you to go through the previous slide. And when you are ready, we will start another topic. I hope you have a good break, and I hope you have time to go back to previous slides. So now let's move on to next. So this is the intraoperative photograph, laparotomy, which is opening the abdomen. And now this is the small intestine. They are holding the small intestine. And now here we can see these structures, which is holding part of on one side of the intestine and to the back of the abdominal wall. This is what we call mesentery. So what is a mesentery? Mesentery is a double layer of peritoneum, which extends from the posterior abdominal wall to the intestine, or from the intra-abdominal organ to the anterior abdominal wall. So depending on where they originate and where they go, if they are going to the anterior abdominal wall, we will call that ventral mesentery. And if they are going to the posterior abdominal wall, we call them dorsal mesentery. And as you can see here, in the mesentery, what do we have? We see blood vessels here. We see lymphatics here. And therefore, mesentery contain blood vessels, nerve, and fat. Let's talk about the ventral mesenteries. Ventral mesentery, like from the intraperitoneal organ, and they will extend to the anterior abdominal wall. For example, from the liver going to the anterior abdominal wall, that is what we call falciform ligament. So falciform ligament is a double layer of peritoneum, which is running from the liver to the anterior abdominal wall. And there is another peritoneal sheath, which is running from the liver to the lesser calf of the stomach. Dorsal mesenteries are more common. They are originating from the posterior abdominal wall. For example, like greater omentum, the omentum we first saw once we get into the abdomen, and the lino-renal ligament. Lino means spleen, renal means kidney. The ligament which is running from the kidney to spleen, it is also dorsal mesentery. And mesenteries of the small intestine, as you saw from the previous picture, which is attaching to one side of the intestine, and the other portion is originating from the posterior abdominal wall. Transverse mesocolon, like the mesentery which is holding the transverse colon, is called transverse mesocolon and sigmoid mesocolon. So now we start talking about mesentery. So we need to understand the peritoneal lining of the abdomen, peritoneal cavity, and the peritoneum. So what is peritoneum? Peritoneum is a serous membrane, like it is equivalent to pleura. It is equivalent to pericardium. Inside the abdomen, these are called peritoneum. It is serous membrane. It is originate from mesothelial tissue, which derive from mesoderm, but it expresses both mesenchymal, which is more like connective tissue, and epithelia, which is like the epithelium, like squamous epithelium, columnar cuboidal epithelium, as you remember. So they tend to play both ways. We have two layers of peritoneum, which are parietal peritoneum and visceral peritoneum. And the peritoneal cavity is between these two layers. So now have a look. We open, this is the cadaver. So this is the right side where we can see the liver. This is on the left side, we can see the spleen. Once we open the abdomen, we are going to see the fatty sheet structure, which is covering nearly every part of the abdomen. That is what we call greater omentum. And like another ventral mesentery, which we talk about, running from the liver to the stomach, this is what we call lesser omentum. And now these mesenteries, which are attaching one side of the intestine, large intestine, transverse colon, or the small intestine, and they are taking to the back of the abdominal wall, they are called dorsal mesenteries. So I hope you can see the ventral mesenteries and dorsal mesenteries. So this is the transverse section of the abdomen. This is posterior, where we have our spine. This is anterior. And this is the gastrointestinal tract in cross section. If you look at that, the peritoneum is covering the posterior abdominal wall, and it also extend and cover to the inner aspect of the anterior abdominal wall. And if the peritoneum extend from the posterior abdominal wall to the intestine, that will be called dorsal mesentery. And if the peritoneum arising from the anterior abdominal wall to the viscus, it will be called ventral mesenteries. So by doing so, by lining the interior aspect of the abdomen with the peritoneum, we have created and we have pushed down and stacked some of the structures to the posterior abdominal wall. They are lying just immediately posterior to the peritoneum. We are going to call them retroperitoneal organs. Retro means posterior, peritoneal, posterior to the peritoneum organs. For example, like our kidneys on right and left, the ascending colon and descending colon. During the rotation of the cat, these structures go and stack to the posterior abdominal wall, and they are cemented to the posterior abdominal wall by the peritoneum, and they become retroperitoneal structures. So this, if you want to think about the peritoneum again, like you have to draw along the posterior aspect, the posterior peritoneum, which come backwards and then fall on the liver, covers the liver, and then which go down and follow, and it covers the stomach and it fall forward, and that sort of stuff. So this is my attempt to go and follow the peritoneum, which is covering the posterior abdominal wall, which is covering the inner aspect of the anterior abdominal wall. And finally, at some point, they will swallow the intestines, and at some point, they will fall and double fall. And by doing so, now we have the blue structure. look at this blue structure, which is the peritoneum, which is covering the inner surface of the posterior abdominal wall, which covers the uterus, bladder, and covers the inner aspect of the anterior abdominal wall, which goes up and fall down, covering the liver, come back again, like another sheet of peritoneum, which is colored with brighter blue, go back here, come back here, double layer of peritoneum, which is going from the liver to stomach. That is what we call ventrum mesentery. And this is what we call transverse mesocolon and the mesentery itself. And now this is the cross section, like our kidneys, our abdominal aorta, and inferior vena cava become retroperitoneal structures. And if you look at this diagram, this is the right side, this is the left side, this is the transverse section or axial section. This right kidney and left kidney, they become retroperitoneal structure. And this is the stomach and pancreas. Again, it is the retroperitoneal structure. This is the large big shadow, which is the on the right side. This is the liver. So I hope you can understand some MRI scans. And if we translate it here, that's simple. That vertebral body, posterior, this is the left kidney. We have the pancreas here, and our ascending and descending colon, which will be contained and cemented to the posterior abdominal wall and covered by the parietal peritoneum and the abdominal aorta, the duodenum, aorta, and the inferior vena cava. They will be covered and they will be in the posterior abdominal wall. So now let's have a different conversation about the gastrointestinal tract, the process. So it starts from our mouth, which we call oral cavity, and continue all along, and it will end as the anal canal, which is our back passage. So the mouth, the function of the mouth, the function of the stomach, the function of the small intestine, and function of the large intestine. So the mouth is for ingestion and mechanical breakdown. And esophagus, which is the swallowing tube, it is for propulsion, sending the food from the mouth to the stomach. And starting from the stomach, digestion and absorption start. Small intestine, large intestine, and finally they will become, all the nutrients will be absorbed into the circulation, the blood vessels and lymphatics, and the waste products, which become feces, will be stored in the sigmoid colon and rectum, and finally pass through the process called defecation. So that is our alimentary tract or gastrointestinal tract, which is starting from the oral cavity and finish as the anus. I want you to remember this, the developmental anatomy. So our gastrointestinal tract from mouth to the anus could be divided into three main portions, which are called foregut, which is at the forefront of the gut, intestine, midgut, middle, and hindgut. So the best thing to remember is our midgut. Midgut starts from the lower duodenum down to the proximate 2/3 of the transverse colon. So if you remember the blood supply of the intestine, this is where the superior mesenteric artery supply. So superior mesenteric artery, starting from the duodenum, jejunum, ileum, cecum, appendix, ascending colon, down to the proximal two-thirds of the transverse colon. And therefore, the superior mesenteric artery is artery for the midgut. Anything before the lower part of the duodenum, like esophagus, stomach, upper part of the duodenum, liver, gallbladder, pancreas, even the lungs and the trachea, they are included and they were developed from the foregut. And after the proximal two-thirds of the transverse colon, the distal one-third of the transverse colon down to the rectum and upper inner canal, they are included in the hindgut. So I want you to have a look at this, and I want you to think about the intraperitoneal organs and retroperitoneal organs. Retroperitoneal organs are duodenum, ascending colon, descending colon, rectum, and pancreas. And the transverse colon here, transverse colon, which is in the intraperitoneal cavity and hanging from the posterior abdominal wall with transverse mesocolon. So now let's start to think about the different layers of the gastrointestinal tract. If you remember the blood vessel wall anatomy, how many layers do we have in our blood vessels? We said 3: tunica intima, media, adventitia. Tunica intima is the endothelial layer, which is made of flattened squamous cell. Tunica media, middle layer, is made of muscles, and tunica adventitia is made of connective tissue. The same thing, like, for the heart has endocardium, myocardium, and pericardium. The same thing, like our gastrointestinal tract, we have the mucosa, marcellia, and serosa. But in this gastrointestinal tract, we have one extra layer, which is underneath the mucosa, and therefore we call it submucosa. So for the gastrointestinal tract layer, there are 4 distinct layers, which are mucosa, submucosa, muscularis externa, and serosa. So if you look at the mucosa layer, it has got 3. Of course, mucosa is made of epithelium, which is usually tall columnar epithelium, because the epithelial cell of the gastrointestinal tract, we have to do absorption and secretion of nutrients and intestinal secretion. Therefore, they will need a columnar epithelium. Epithelium need to rest on the connective tissue, which we call lamina propria. And even underneath the lamina propria, we have one small, very small marcellia, which we call muscularis mucosa. This muscularis mucosa, when they contract, they will stimulate the glands which are present in the muscular, which are present here. As you can see, a gland in the mucosa. These muscularis mucosa, when they contract, they will stimulate the glands in the mucosa to secrete. And then we get to the big marcellia, which we call muscularis externa. In contrast to the arteries, we have here in the intestine, we have 2 layers of muscle, which are called circular layer and longitudinal layer. Circular layer of the muscle, when they contract, we narrow the intestine. When they relax, they dilate the intestinal lumen. Longitudinal layers of muscle, when they contract, they will shorten the gastrointestinal tract, and when they relax, they will lengthen the gastrointestinal tract. By doing so, there will be contraction and relaxation. distance shortening and lengthening. This will give us the propulsion, digestion of the food which is present in the intra-abdominal, intraluminal contents. And the outermost layer is, of course, serosa, which is made of usually peritoneum, which is both, like as you saw from the previous slide, which we develop into epithelial and connective tissue, and therefore they will have both epithelium and connective tissue. So I hope you get this explanation. Right. So now the different parts of the gastrointestinal tract. So as we said, we start from the mouth or oral cavity. Inside the oral cavity, we have our tongue and the salivary glands, which are somewhere here, the parotid gland, sublingual gland, submandibular gland. These are the extrinsic salivary glands. Of course, intrinsic salivary glands will be inside the mouth and around the tongue. And then once we eat the food, we get into the oral cavity, we chew, and we start swallow. It goes into the pharynx. From the pharynx, it goes along the esophagus, which will be transported into the stomach. From the stomach, it will go into the duodenum, jejunum, and ileum, which are the parts of the small intestine. And finally, it will go to the cecum, ascending colon, transverse colon, descending colon, sigmoid colon, rectum, and anal canal. So let's try to understand about our mouth, which is also called oral cavity. So anterior boundaries, we have lips. On the lateral side, we have cheek. And when we open our lips, we have orifice, and posterior to the oral cavity, which is the pharynx, we call it oropharynx. Yeah, the portion of the pharynx posterior to the nasal cavity is called nasopharynx. And then portion of the pharynx, which is posterior to the oral cavity, is called oropharynx. And the upper boundary of the oral cavity will be hard palate and soft palate. Lower boundary, we have tongue here. And oral vestibule. Vestibule is the place where we brush our teeth. It is between the tongue, between the lips and our teeth. And the oral cavity proper, which is where we eat our food. So these are the different portions of the oral cavity. The mouth or the oral cavity is lined by the squamous epithelium because it is exposed to multiple friction by eating and chewing food. And therefore we need wear and tear epithelium, which is the squamous epithelium, stratified squamous epithelium. Of course, epithelial cell will have to rest on the connective tissue, which we call lamina propria. And then we have submucosa, well, not in the oral cavity. And in some part of the oral cavity, we will have keratinization. And if we look at these picture, these are the muscles of the face, muscles of the head and neck. The muscle around the oral cavity, orifice, it is called orbicularis oris. Oris means orbicularis means orbitally surrounding oris, mouth. Similar name muscle we have around the eye, which we call orbicularis oculi. In the temporal region, we have the temporalis muscle. Just on the superficial to the angle of the jaw, we have the masseter muscle. So I want you to remember masseter muscle, temporalis muscle, orbicularis oris and orbicularis oculi. Because this temporal muscle, masseter muscle, they are important in chewing. And we have a group of muscles which does the job for chewing. In other terms, it is mastication. So muscles of the mastication, muscles of the chewing, they are masseter muscle, temporalis muscle, medial and lateral pterygoid muscle. These four muscles in combination, they will move the jaw right and left. They will protrude the jaw. They will retract the jaw. They will depress the jaw. By doing so, all these synchronized action will help with the chewing process. And the cheek, which is made of bassinator. Here, bassinator muscle. Bassinator muscle. So this bassinator muscle is keep the food in the oral cavity, and especially when we are choosing by contracting the bassinator, the foods remain on the teeth. And lips are made of orbicularis oris. Now let's have a look at our tongue and the palate. Of course, you remember the hard palate and soft palate. And if we look on the dorsal surface of the tongue, we will see something like that. Here, we can see the terminal sulcus here, which is like a V shape. And just in front of the terminal sulcus, we have another V-shaped lying papilla. These papillae contain taste buds. And on the either edge of the tongue here, we have the foliate papillae. They also contain taste buds. And on the dorsum aspect anterior tip, we have the fungiform papillae. They also contain taste buds. So now we know fungiform papilla, velate papilla, and foliate papilla, they all contain taste buds for taste sensation. And here, very at the tip, filiform papilla, which is near the tip of the tongue, they are there just to roughen the surface of the tongue, especially for something eating like ice cream, just for licking and taking in. And the muscles of the tongue, we have intrinsic muscles and extrinsic muscles. Intrinsic muscles of the tongue, they just change the shape of the tongue. They do not have the property to move the tongue forward or backwards or moving medial or lateral. Intrinsic muscles of the tongue, their job is to change the shape of the tongue. Extrinsic muscles of the tongue, their job is to move the tongue, for example, like moving the tongue forwards or backwards or medial sides or lateral side. So these are the four papilla on the dorsum aspect of the tongue, which contain taste bud and which do not. And this is the oral cavity. If you open your mouth and say ah, you will see the uvula and you will see the posterior wall of the oropharynx. This is our tongue. And let's talk about the intrinsic muscles of the tongue. They are longitudinal, transverse, and vertical fibers. And remind you, intrinsic muscles, they do not move the tongue, they just change the shape of the tongue. Extrinsic muscles of the tongue, we move the tongue forwards, downward, backwards. They are styloglosses. They arrive from the styloid process to the tongue, styloglosses. Hyoglosses, it extends from the hyoid bowl, go to the tongue, hyoglosses. Genioglosses, from the mandible, going to the tongue. So styloglosses, hyoglosses, and genioglosses, these are the extrinsic muscles of the tongue. So for the completeness, let's talk about the teeth. These are the permanent teeth. We have wisdom teeth. We have molar, first molar, second molar, and third molar on both sides. And we have canine, and we have incisors. So central incisor and lateral incisor, canine, and then premolar, first premolar, second premolar, and then 3 molar. The last molar or third molar is called wisdom tooth. So this is the longitudinal section of the tooth, which is impacted in the mandible. The portions are the one we can see, which we brush the teeth. It is called crown. And in the gingiva, it is called neck, and the portion of the teeth which is inside the mandible bone, it is called root. And here, to show you again, the muscles of mastication, which include temporalis, masseter, and medial and lateral pterygoid muscles. Salivary glands. So salivary glands, they are intrinsic and extrinsic salivary gland, or major and minor salivary glands. Minor salivary glands are present in the oral cavity, in the tongue, lips, palate, and they just secrete saliva into the mouth. Major salivary glands lies external to the mouth. For example, our parotid gland, submandibular gland, which is below the mandible, and sublingual gland, which is below the tongue, they enter into the oral cavity via their ducts, DUCTS ducts. Saliva contains bicarbonate, antibacterial, antiviral, and antibodies. They contain enzymes and cyanides, and therefore saliva is precious. So now let's look at the location of the parotid gland, which is just in front of the ear. It opens along the parotid duct into the oral cavity. Submandibular gland beneath the mandible, and sublingual gland here underneath the tongue. They have their ducts to open into the oral cavity. Pharynx, which is what we call throat. Pharynx has 3 portions: oropharynx, naropharynx, and laryngopharynx. When we talk about pharynx, we need to talk about pharyngeal constrictors muscle. We have 3 pharyngeal constrictors. Start with the suprahyoid muscle, 3 pharyngeal constrictors, and infrahyoid muscles. So let's look at the picture to make it more clear. Here, the oropharynx, which is just posterior to the... So now we can see the 3 pharyngeal constrictors. These are superior pharyngeal constrictor, middle pharyngeal constrictor, and inferior pharyngeal constrictors. These pharyngeal constrictors, if you look at the direction, very horizontal, it's very oblique and slightly oblique, slightly horizontal. By these pharyngeal constrictors, what do? Once the food comes into the pharynx, they will contract and they will push the food down into the esophagus. That is the job of the pharyngeal constrictor muscles. Now that's the end of our lecture. We will have to continue with another lecture, which I have mentioned, part 2 for the gastrointestinal tract and abdomen. Thank you.